February Controversies in Cardiology. Today we were privileged to have as our guest one of the most prominent cardiologists in outcome research in the last 15, 20 years, certainly is one of the pioneers in the field, Dr. Harlan Krumholz, who is highly sought after, and today's topic is something that he himself has written a controversial piece in JAMA just a few months ago. Let me just tell you a little bit about the next controversies is with Dr. Scott Gottlieb from the FDA, and we're going to have a one-on-one discussion with Dr. Fuster. Instead of a formal panel, it'll sort of be an informal discussion about the present state and future of health and cardiovascular health in the United States and globally. Today's topic, again, is very, very interesting, is management of lipids in 2018, and Mike Cavallis will give us a brief overview.
Thank you. Just want to say thanks to Dr. Krumholz for coming today. It's been great hearing your perspective on different things, and looking forward to hear what you have to say about lipids as well as the rest of the panel. So the benefit of LDL cholesterol reduction in primary and secondary prevention of cardiovascular disease using statins is well established. The approach to LDL reduction has been debated more recently as conflicting recommendations exist between guidelines on whether using LDL targets or varying intensities of statins based on risk reduction is more appropriate. The treat to target LDL model, as proposed by earlier ACC-AHA guidelines, describes the dogma that the only rule necessary is the lower the better. However, this method of treating to target is not directly supported by evidence from large randomized controlled trials. In 2014, the ACC-AHA guidelines deviated from the message of previous guidelines in recommending moderate or high intensity statins for prevention of cardiovascular reduction events based on risk reduction rather than focusing on specific LDL targets. Instead of eschewing the hypothesis that lowering LDL may be better for cardiovascular risk, the ACC-AHA guidelines reflect adherence to a more strict evidence-based approach using the best available high-quality evidence instead of considering observational studies and expert opinion. A more recent focus update by the ACC in 2017, however, reincorporated the concept of LDL cholesterol lowering to target in conjunction with focus on the risk of risk reduction. This occurs in the wake, though not necessarily in response, to more recent studies IMPROVE-IT and the Fourier trials, which showed LDL reduction and cardiovascular disease benefit with non-statin medications. With the availability of potent LDL-reducing medications showing cardiovascular benefit, such as Zetia and the PCSK9 inhibitors, the issue of targeted LDL goals again becomes a more relevant discussion, as it's now possible to achieve LDL levels less than 70, even for patients with severe LDL elevations. The dramatic reductions in LDL cholesterol to below even 30, as seen in the Fourier trial, additionally swings the pendulum perhaps in the opposite direction and questions whether there is a safe lower limit to LDL reduction. Regardless of treatment, the issue of risk stratification for primary prevention of cardiovascular disease is complex. Guidelines use a multitude of cardiovascular risk calculators, which differ in variables analyzed and may not, on a population health level, reflect a diversified and modern patient cohort. The pooled cohort equations used by the ACC-AHA have been shown to overestimate the true number of cardiovascular events on the magnitude of 64 to 78%. A more recent study, which enrolled patients between 2008 and 2009, suggested an even higher overestimation of about 167% of cardiovascular events. Notably, the pooled cohort equations and other risk calculators rely on the use of traditional cardiovascular risk factors and may fail to capture the impact of unidentified yet important risk factors for the development and progression of cardiovascular disease. This theory is supported by recent studies that identified subclinical atherosclerosis in the absence of conventional risk factors. One study evaluated patients considered to be free from cardiovascular risk and found that nearly 50% had subclinical atherosclerosis in the presence of normal LDL levels. The study showed a linear association with increased LDL cholesterol and the development of subclinical atherosclerosis. LDL cholesterol was also independently associated with varying extent of early systemic atherosclerosis in the absence of major risk factors, perhaps favoring a treat-to-target approach. Of note, LDL levels of 50 to 60, there was no subclinical atherosclerotic disease present. On the molecular level, risk stratification, one study evaluated over 48,000 patients by genetic risk score based on 27 genetic variants and found a significant association with these genetic variants and the risk of coronary events. The authors also noted greater absolute risk reduction with statin therapies in genetically higher risk patients, thus suggesting there may be additional metrics to further stratified risk reduction with LDL lowering medications based on non-traditional risk factors. In conclusion, with the recent introduction of efficacious LDL cholesterol lowering medications, the future of cardiovascular disease prevention includes medications that can significantly decrease the risk of coronary heart disease or its development altogether. In this view, the question of whether LDL lowering therapies should aim to achieve LDL targets or whether focusing on individualized risk reduction is more important now than ever. The need to discover additional risk factors and evaluate non-classical cardiovascular risk stratification for patients has also been brought to light in recent studies, and the future will likely involve more sophisticated models for risk evaluation in choosing a patient's strategy of LDL reduction and further risk modification. Thank you.
Thank you very much, Michael, by working on a topic that is not simple, although for many it's very simple. We'll see. Well, it's a pleasure today to introduce an outstanding individual in every sense of the word, Dr. Harlan Krumholz, a good friend, and again, a superb investigator and with a very good head. Well, he was trained, he went to college at Yale, then he moved to Harvard Medical School where he obtained the MD degree. And then he had his internship and residency in medicine at the University in California, San Francisco, and he was actually chief resident at Moffitt Hospital. Then he moved to Boston, where from 1989 to 1992, he was a cardiology fellow at Beth Israel. And then he went back to Yale, where he became assistant professor of medicine in 1992. And over a period of actually 10 years, he moved from assistant professor to associate professor to professor of medicine and epidemiology and public health at Yale School of Medicine. In 2005, he became the Harold Hines Professor of Medicine and Epidemiology and Public Health at Yale School of Medicine. And in addition, he's director of the Center for Outcomes Research and Evaluation at Yale, and he's also co-director of the Robert Wood Johnson Foundation Clinical Scholars Program at Yale School of Medicine. Now, he has, as expected, a large number of awards, which began in college with magna cum laude and other honors. Then in San Francisco, the most outstanding medical intern, finalist of the American Heart Association Young Investigators Award, the American Society for Clinical Investigation. He became a member, as well as the Institute of Medicine, today the National Academy of Medicine. Distinguished Scientist Award of the American Heart Association and Distinguished Achievement Award of the American Heart Association, and more recently in the top 10 distinguished international cardiologists according to the Chinese Society of Cardiology.
They can stop now. What? It's enough.
Just sit down, please. Okay, so interestingly, he's a member or chair of 151 committees. I've never seen this before. So amazing. That I am going to escape. Yeah. NIH, AHA, ACC, Academy of Medicine, etc., etc. Now, the question is in the editorial board of all the journals that you can imagine: American Journal of Medicine, American Heart Journal, JACC, Circulation, etc. And then the most interesting issue is he's a very original person in terms of his career. If you go to his curriculum vitae, which is, well, his bibliography, I mean, near 1,000 papers, you see socioeconomics, you see quality of care, you see epidemiology, you see promoting health and preventing cardiovascular disease. And what is interesting, in all the subspecialties in the cardiovascular field. So I think there's no subspecialty, whether it's valvular heart disease or acute coronary syndromes or anything that is missing on these aspects that has been really, he has been a pioneer and very passionate about it, as you all have seen today in his presentation at noon. Well, now you can come in here, my friend. You have the option to come and have this plaque to hang in your office. The check is not so substantial. It's more symbolic. And, you know, from all of us to Harlan Krumholz for outstanding teaching, wisdom, and expertise as the Anandi Sharma visiting professor in the Simon Dag Memorial Lecture, February 26. Congratulations. Thank you so much.
Good. Thank you. Thank you. You're in the middle over there. Thank you.
Okay, so cholesterol. Let's talk about cholesterol. I have to say that I had to do a lot of reading about it. We all know about cholesterol, but if you want to chair, here in the middle, you are too far. If you want to approach this subject well, you really have to do a lot of, you have to read a lot, and what is new is changing very rapidly. Some people talk about the small particles, large particles, all sorts of new things that I think are pertinent to be discussed today. So let me call the experts. Jeff Mechanic. Jeffrey, where are you? Good. Jose Meller, Bob Rosenson, Donald Smith, and of course Michael, who made the presentation. Now, when Martin Goldman asked me to address this issue, I had a chill, because to approach cholesterol, you can approach it from 1,000 points of view, and whatever you do, you may miss something important. So I will try to do the following. I have never done it before, but we'll try this time. So what I did is I pick up the editorial that Dr. Krumholz wrote in JAMA very recently, and he made 15 points. So I think it's a good time to discuss each of them, and then go over into what is new, what is more, less new, what is controversial, and so forth. So I took this approach, and I have to tell you, I really work on each red dot is a question. So let me begin by saying, and starting with the first statement that he made in this editorial comment, when the American College of Cardiology, American Heart Association published the guideline on the treatment of blood cholesterol to reduce atherosclerotic cardiovascular risk in adults in 2013 with only the use of statins, and then he goes on, a lot happened. You know, there was a lot of controversy. And then the controversy, if I recall at that time, was that up until then we used to have a goal, and that is, what is the ideal LDL cholesterol level that you have to achieve when cholesterol is elevated. And the approach that these organizations took is to really go to the literature, very well done, I think, and then they start with a patients who have a risk factor profile, and then from then on, you treat it with high dose or medium dose and forget about what is the cholesterol level at the very end. This really was a huge change in the approach that we had until that time. Now, by reading your editorial, it seems to me that this didn't cause too much of a concern to you. Is this correct?
That's correct. No.
Good for you, short answers. We have a lot to cover today, but you can go on.
Well, one of the things, the reason that I suggested that we might do this topic is because I think there's a lot of misperceptions about what was being suggested at that time and why was this push away from the targets. And it devolved into a debate about whether lower was better or whether we had proved lower was better. And it was a misunderstanding, I believe, because the reason that this evolved was the recognition that there are no perfect surrogates. There are no perfect surrogates for what's going to happen when you implement a drug and to know what would happen with a patient. And there can be no better surrogate than the LDL. I mean, LDL is a very good marker of risk. We know it's intrinsic to the mechanism of disease. And we know we have evidence that when you manipulate the LDL, that you can lower risk. And so from a perspective of accepting that as a marker of what would happen with the drug, there can be no better one. But I was very influenced when the Illuminate trial was published, and we saw that torcetrapib, which could lower LDL by 25% and increase HDL by 75%. So take the HDL part out because we still are debating that issue. But just take the LDL. Torcetrapib lowered it by 25%. And the people on torcetrapib compared with placebo had higher mortality rates. We still don't know why that happened. And when you look at the cholesterol esterase transfer protein inhibitors, dalcetrapib, they didn't pan out. Even anacetrapib had only a modest benefit, and we don't know why there was a difference between those within the class. So it led me to start to advocate with the committee. I mean, this started before. I wrote an open letter that I published to the writing committee, where I said, if you look carefully, if you identify a target agnostic to the strategy that you employ to the target, then you're opening the door to the use of strategies that have yet to be demonstrated to have benefits for the patient. What that means is that if I simply say you have to get them under 100, and this was before Improve It was published. Improve It, by the way, only a 6% relative reduction in mortality compared with almost 20% you get with statins. But at that time, we didn't even know whether ezetimibe would have the effect that we saw with statins. And by just simply picking a target, you're opening the door for someone to go around the statins and start with ezetimibe, because if it's only about the target, it's just about getting the number to the right place, let alone it was an arbitrary number to begin with. And the argument was, you need to be, you can look epidemiologically, you can look at the relationship between risk, but to know what the effect of a drug is, and just to finish this thought, the drugs have thousands of effects on the human body. The LDL is a single biomarker. To understand whether there are offsetting positive or negative effects, you can only tell by testing it within a trial and seeing what the effect is on people. It could be that it has positive pleiotropic effects, so actually you even get benefits beyond what you might have expected. It could have that it has offsetting effects, which nullify the benefits that you would have expected from the LDL. But by simply saying we're just trying to drive down cholesterol, agnostic to the strategy, you're saying we don't need to actually know what happens when you treat people this way. And the Illuminate trial, after Illuminate, we couldn't possibly just assume that because it made someone's lipid profile look better, that we could be confident that people's risk would decline. So in the end, this wasn't an argument about whether targets were a good idea or not. It was an argument about whether you were using evidence-based medications. And on the course of evidence-based medications, we had plenty of information that using a basic statins reduced risk by about 20%, Going to high-intensity statins, you got about another 15%. And at that time, that was pretty much what you had, besides ileal bypass and a few other very early studies which had shown benefits for patients. And this is why the committee was prevailed upon. I have to give them great kudos. They came from a very traditional point of view. They walked into that, there was no iconoclast on that committee. There were people that were from...
Well, look, take a deep breath in, because we have many things to discuss.
I'm running out the clock before your questions.
You made your point. Now here, later on, we'll discuss whether even cholesterol should be measured. So let's go into Dr. Rosenson. There are 5 different guidelines recently about how to approach cholesterol, and amazingly, all are different. And this is where the confusion begins. We have the American College of Cardiology, American Heart Association, the European Society, the Canadian Society, the UPSTF, and the Veterans Administration. I can only give as a summary the following. First, the European is the most aggressive approach in terms of what they look at and what patients are being treated. We'll go into the details later. Actually, the Canadian is the most conservative one, and the American is actually intermediary. But here is the question. All of them, contrary to what the discussion, all of them start with a risk factor profile that they quantify by different means, different formulas. Okay, but here is one, which is the American one. You don't look at an endpoint, as mentioned by Dr. Krumholz. You don't look at a level at the very end of cholesterol. But all these start in the same way. The other two, they look at the final level, but also the formula is different. For example, in the American Heart Association, you look at simply whether there's a myocardial infarction, a stroke, or coronary heart disease as a first event. The European looks at fatal events in this formula. And the Canadian looks at the Framingham risk score, which is very similar to the American one, but actually they look at all the events, not at the first one. I'm only presenting this to you, Dr. Rosenson, because it seems it's a mess.
I think that we need to understand that our healthcare system is a very high-cost system, and taking into consideration the economic costs of procedures, hospitalizations, disability, that approach looking at multiple endpoints and expensive procedures, PCI bypass surgery, I think is an important consideration. The evidence really is in secondary prevention supporting high-intensity versus low-intensity statin. And just to add to what Harlan mentioned, we knew and have known for a long time that statins do not just lower LDL cholesterol, they're doing other things that are very important in terms of reducing inflammation, pro-inflammatory cytokine production, circulating levels of CRP, stabilizing the plaque and thickness of the fibrous cap. So I support the high-intensity statin approach, but the data predominantly derives from people with coronary disease, typically ACS. But there are other studies of statins that have often been placebo studies, or essentially placebo studies, in people with diabetes, hypertension with 3 or more risk factors, and showing that moderate intense statin provides a tremendous amount of benefits, such that, let's say, the CARDS and the ASCOT lipid-lowering study were stopped prematurely because the event reduction was so, overwhelming. So that takes into account the clinical trials and some of the risk factors. With regards to the pooled risk equation, we have a study that we sent for the European Society of Cardiology meeting. The number of 7.5% is incorrect. And we can better calibrate that model, and we've compared all the risk tools against each other and validated in the REGARDS study. But I think the pooled risk equation is good, but the 7.5% cutoff is not the right number.
We'll discuss this in a moment. But you know the end result, Dr. Krumholz? Interestingly, if you use the ACC AHA guideline, 43% of the adults in this country should be on statins. If you use the ESC guidelines, 39%. If you use the Canadian one, 46%. So at the very end, whatever guideline you use, which are all different, at least you treat the same number of patients. The question is whether the endpoints are going to be the same in terms of events. But this is interesting that at the very end, you end up with something very similar. In other words, perhaps it's a chaos, but on the other hand, you end up treating the same number of patients regardless of the guideline that you follow, which is interesting. I have a question to you again, Harlan. You say on your second statement that, of course, a recent report estimated that the treatment of 10,000 patients for 5 years would cause 1 case of rhabdomyolysis, 5 cases of myopathy, 75 new cases of diabetes, and 7 of hemorrhagic strokes, pointing out that the benefit is much more significant, according to all the data in the literature, than the side effects. But I was surprised, though, and I want to get into the side effect situation. It is surprising when you mention that there are only 5 cases of myopathy out of so many people, when in fact, the literature that has evolved recently in terms of myalgias is about 5 to 10%. And you mentioned 5 cases out of 10,000. Where do you got this data from?
Well, I think this is a very interesting area, this issue of what people are describing as side effects from statins. I took it from the systematic reviews, the CTT data, but I think that what's emerging is that there's a lot of people who attribute their symptoms to statins, but when you look at the trials, you fail to see it. In clinical practice, we hear it reported a lot. But I was very impressed by the N of 1 trial that was published in Annals, where a lot of people who were on the placebo phase of the N of 1 trial were reporting myalgias. And it seems that I very much like the notion of using N of 1 trials to try to isolate whether or not side effects, which are bothersome and very real to the patients, are truly attributed to particular medications. But in that particular case, I was pulling from what they've said. We did our own systematic review of side effects from the trials we published in Circulation maybe 15 years ago. We also found very little evidence. Now, what people said to us, well, they weren't collecting it rigorously enough. They weren't thorough enough in the trials in collecting this information. But what was interesting is whatever they were doing, when they were blinded, they were unable to find an important signal. And in these N of 1 study in Annals, which I recommend to you, it also is very difficult to detect. That does contrast to our own experience when people are complaining a lot. But in that N of 1, the prevalence of the complaints were actually quite high. It just, they weren't predominantly within the statin group. I don't know, Bob, or any of the others.
I don't know. Look, Harlan, everybody here who sees patients constantly, the situation is, I would say, differently. First of all, there's a confusion here. Myopathy, yes or no? Let's do a CPK. Excuse me, CPK is positive in 25% of the myopathy patients who have ARDs on statins. Number one, that's to start the confusion. I just had a patient yesterday, actually. I call a patient, says, started on one of the statins and 3 other drugs at the same time. And he says, I have nausea in the morning. I have nausea in the morning. I had talked to this patient 3 weeks ago with the nausea. They stopped the drug and says, doctor, it's a miracle, it's gone. We see this all the time. What I'm saying is, this is not a drug that is free of side effects. The thing, all these trials, you really have to be almost dead to call a side effect. And I just want to ask Don, what is your experience?
With the side effects and what?
Yeah.
Yeah. The side effects are many. An NHANES trial looked at the myalgias. Myalgias, when people complain of them and you put them in studies and you put them on placebo versus a statin, what you find is only 37% really realize, what's the difference between the myalgia on a placebo versus on a statin. So that 63%, or 2/3 of people who complain of muscle aches and pains with statins, if you were on a placebo, they couldn't tell the difference. The other thing was the NHANES trial, which really looked and said, are you on a statin and do you have muscle aches and pains? And they looked at that, and they're always symmetrical. And that was one of the differences between whether they were true statin sort of related things. And the second thing is they're in the lower extremities. So those are the two things that really sort of point you to more that you're having a statin type trouble as opposed to a unilateral myalgic problem or more upper extremity type things. So I think there are ways of looking at that and trying to help people. But the main thing is you have to stop them. The main thing is to getting the patient to have confidence that you're listening to them and trying to help them figure it all out. And if you don't do that, forget it. You're nowhere, sort of.
Thank you, Jose. The third statement by Dr. Krumholz has a lot to do with the risk factors that sometimes go along with the high cholesterol, blood pressure, lack of exercise, the diabetes and the obesity and so forth. And I just like to point out that we just finished a study which supports completely the study done by Yusuf across the world. What we did is we look at subclinical disease in 4,000 people with 3D ultrasound, and we compare the people using only the 5 risk factors that we call BWAT, which is the risk factors about blood pressure, is the B, exercise, the W is weight, A is the type of alimentation, and T for tobacco. And we compare these 5 risk factors with the 7 when you add blood sugar and cholesterol. And we quantify subclinical disease in 6 different regions, no difference at all. And that is pointing out that how important is cholesterol when you take care or you don't take care of all the other risk factors. I'm just saying because the obsession for cholesterol certainly came from pathology, and there's no question it's an important risk factor. But I think it gets diluted a little bit when you put all the other risk factors together. And I'm just asking you the question because it's a critical question. Today we can go to a developing country and use 5 risk factor profile without going through the torture of drawing blood and cost. And you get into very similar risk factor profile.
I think that if you have only one risk factor, it might not be a major problem, except that very high cholesterol, if by itself, we see that creates a lot of atherosclerosis. But I think that when we see a patient who has something else, significant hypertension that's not well controlled, and he also has modest amounts of elevation of LDL, it does play a risk on, it augments the risk of developing atherosclerosis. So I think all of them together become a major problem. If somebody is smoking and has a high cholesterol, I think that there is more cardiovascular events. If it's only the cholesterol, it will take much longer to develop a problem. So it all depends on how much you follow patients. That's my sense.
Harlan, do you agree with that? That in fact, one of the reasons why even the American Heart Association, American College, they start with a risk factor profile from the top is because this in itself has a tremendous power. It's not correct? I'm excluding cholesterol.
Well, I think it's a really good point. Maybe it would refocus us if we're talking about the factors in addition to blood pressure, but besides that, all the others are behavioral, and the blood pressure is influenced by the behavioral. It's a very powerful approach to reducing risk and to looking at it together. I think the reason that we are interested in the LDL is because there are a small number of people with markedly elevated levels who are putting themselves at substantial risk, and it could be abrogated. But I think that on a population basis, particularly in a resource-poor environment, we needn't feel bad if it's difficult to obtain an LDL cholesterol. We can focus on behaviors that are highly associated. It's a complex disease which is highly influenced by behaviors, and those behaviors are going to be linked with and highly correlated with that risk. So you can probably, in many cases, avoid that and focus on the things that can be changed if you want to make a biggest impact on population health.
Good. Thank you. There's a fourth issue that comes in the editorial and is interesting. You know, statins may not achieve what you want. For example, in familial hypercholesterolemia, which we will be discussing later. And you mentioned the IMPROVE trial where ezetimibe was added, and actually it dropped the cholesterol further, and the incidence of events at 7 years moved from 34.7 to 32.7, which is not much. This is not my question. My question is when later on they look at the data again, there is a statistical issue, and that is you can look at the first event and you get a statistical significance, but it's not very significant in a way. But if you look at all the events that go on 7 years, then you realize that the addition of ezetimibe is much more significant than what it was really thought out. And I would like to ask you, because you work a lot on the statistics of things, this is not the way that we should analyze trials, and that is not to look at the first event, which is what usually happens, but rather to look in the long term, all the events that you are actually preventing, where to me, the IMPROVE, this particular study, the IMPROVE-IT study, really is very significant when you look at all the events over 7 years, not much significant if you look at the first event, which is how it was published originally.
So I think that's an excellent question. To me, I agree with you. I think that I'd be more interested in the overall lifetime burden of disease and the degree to which I'm getting. You've got to figure out what you're going to do with mortality, though, because in that case, you're going to wait. No, someone who stays alive and has many events, someone who dies is one. So you've got to figure out what you want to do with death. One of the advantages of time to first event is you don't have to worry about waiting the events. I think that, as you know, you've got to specify this up front, so you need to be wise enough to do that. I want to just add one thing about this IMPROVE trial that I think is very interesting. So they recently published in Circulation a subgroup analysis where they looked at diabetes, and they found a significant interaction. These trialists are enthusiasts for ezetimibe, so what they said was, there was a significant interaction, meaning that you got a greater effect in patients with diabetes. Their conclusion was this thing is even better for diabetics, but what they didn't say was, actually when you look at the people without diabetes, there was no benefit. I thought actually they could have written the paper to say this is very interesting. Ezetimibe seems only to work in people with diabetes. It's secondary subgroup analysis. It's exploratory in nature, but it was significant and important enough for them to emphasize the benefit in the diabetes. They just neglected the bigger message. And I thought, you know, as you know, there's lots of things you can do statistically with these trials, but it wasn't also an interesting observation. So yeah, I'm interested in the total burden, but this heterogeneity effect may be quite important. It's hard to know if there was something going on that way.
Thank you. Michael, you talk a lot about the PCSK9, and it seems you like it a lot. Now, I want to ask you a question. I am very impressed about the drop in cholesterol levels. I'm less impressed about the outcomes, I have to say. You know, in the full year, the outcomes from 11.3% in moving to 9.8%. And then in terms of the most recent information, actually published by the group at TIMI, I believe, there was a reduction in cardiac events, a relative reduction of 15% to 20%, but no effect on either cardiovascular or all-cause mortality. I'd like you to give us your perception, and then I will ask Dr. Rosenson, who is very involved with these trials, are these really a miracle? It certainly is a miracle the way you drop cholesterol down, but I'm not sure about the outcomes, which tells you that maybe part of the statin work, as mentioned, is through other mechanisms that drawing cholesterol down.
I think for the Fourier trial is mostly secondary prevention. So all patients had, you know, clinical atherosclerotic disease. And the LDL reduction that you saw from the PCSK9 inhibitors was proportional to what you would expect from LDL reduction from statin medications as well, which I think suggests that there's additional benefit, although for those patients who already have low LDL levels, the benefits may be smaller as compared with the patient population who has coronary disease and a baseline LDL maybe from more than 190, more than 200. So while the absolute risk reduction was pretty small, the relative risk was good, but the patient population maybe not everyone needs a PCSK9 inhibitor, and only patients who have really hard time getting the LDL levels down is who the medication should be for. As compared with, I think it's a more important study because it highlights maybe not as robust LDL reduction, or cardiovascular benefits, but unlike the Illuminate trial, it's not a bad drug for lowering LDL. There's no worse outcome.
Certainly it's not about drug, but I will tell you, 3 years ago, we thought it was a huge breakthrough, maybe still is. But Dr. Rosenson, you're really very involved with it. Can you give us a summary of what your thinking is, the PCSK9?
Well, from my perspective, I didn't have any doubt that PCSK9 inhibitors were going to work based on Mendelian randomization. I think the big issue is what is the cost effectiveness of a biologic? And I think where they really fell down is that this was a study that was powered for only a 15% reduction in events, and using that kind of a cutoff value where you're including about 28,500 people, you're going to terminate the trial very early. And I think that's the big difference. The study went on for 2.2 years, and it showed the event reduction, of 20% at 2 years, 31% at 3 years. And so I think we have to consider what the study design is and then the content. The longer you lower LDL cholesterol with any, example, statins, the greater the benefit of the therapy. Now, I want to just bring everybody's attention that, in about 11 days or so, the Odyssey outcome study will be presented, and this is a post-ACS population, so higher risk to begin with, than stable coronary disease, and the minimum treatment duration is 2 years, not the average being 2 years. And so I would expect that the Odyssey outcomes is going to show much greater benefit with alirocumab, even though they went to a low-dose, high-dose strategy titration, than did Fourier with the valocumab. So, we need to put things into context. And when you talk about events, the statin studies went on for 5 years, fairly uniformly, and people with stable coronary disease, or the lipid study 6 years. So this is 2 years versus 5 to 6.
Maybe a longer follow-up is what we discussed with the when we talk about the ezetimibe, that maybe looking at events in a long-term cumulative may be helpful. Harlan, there's one problem though. You have been so involved in cost effectiveness. If I recall, I had at least 10 patients that I tried to give the drug, and the company said, forget it. And the patient, one of them had money to pay, or two of them, but the others didn't. $14,000 per year if you want to use one of these drugs, which is 100 times the generic statin. So tell me how you react and whether you see any green light in the future in case that these drugs are a miracle, which is what we are discussing.
Well, I think as you've correctly said that, their benefit needs to be put in context, even for the burden or how people feel about them versus taking pills. Some people will find the injections to be a better approach. Some people don't. The benefit was, 11.3, 9.8 or something like that in that study. And we'll see in Odyssey what we get. We've written about the cost effectiveness, and, it's priced out of what you would think would be a reasonable range for what society is usually valuing this. Most people have suggested to them that they should have the price. If they have the price, that they would do quite well with the drug, and that the insurance companies would come around. I think that at $14,000 to $16,000, it's a very expensive proposition. I'm not in favor of what's happening though, because I really believe if it's approved and it has an outcomes trial associated with it, what the insurance companies are doing is just making it difficult. And they're not actually explaining with great transparency what the path is to get approval for this. And so it's sort of something going on behind the curtain. They're the ones sort of taking responsibility to hold back costs. But I believe it's not transparent enough. I do think as a society, it's up to us to have the discussion. Is this appropriately priced? Should we be paying for it? What should we be doing? But it shouldn't be, you're calling on Monday, the person you get says, maybe on Wednesday, somebody else picks up the phone. Their whole approach is to make it difficult. We need to decide together what the proper approach is and move forward. I don't think that for a given product that's been approved and has outcomes trial data associated with it, that that it shouldn't be completely transparent how these decisions are being made. And then let our societies, let the cardiologists, let the professionals and the patients be involved in these discussions about whether it's appropriate or not. But I can tell you, when we've analyzed it at $14,000 to $16,000, it comes out as a pretty hefty price for what it's producing in terms of value. I think most of the recommendations has been if they have the price, they come in at about the same kind of value as a lot of other things that we're currently paying for in society, and seems much more reasonable. So a lot of us are saying to them, why are you holding it so tight? We'll see if they get an outcomes trial from Regeneron and Sanofi with the Odyssey trial, then maybe it'll bring up more competition. We'll see. But yeah, it's a little discouraging right now, I think, to be calling them and feeling that you've got evidence and want to make a decision, and to have the insurance companies block you for a drug that has outcomes evidence. I think that's discouraging and unfortunate.
Thank you. Jeff, we have shared a few patients, you and I was impressed by, and I'm not talking about diabetes now, I'm talking about that you look at the lipid profile on all the aspects, very low, intermediate, low-density lipoproteins, different particles of HDL, and I always thought this is too complicated. However, there is probably the best paper in JACC of this year, was just published a few weeks ago, and this was basically the following. First of all, they got the data from China. You know, the Chinese, and I think Harlan has a lot to say about it, have an incredible biobanking of materials, including blood samples from all the hospitals. So a number of investigators got hold of that data, and the data was very well tabulated, 912 myocardial infarctions, over 1,000 ischemic strokes, and about over 1,000 hemorrhagic strokes. And they look at the very low, the intermediate, and the low-density lipoprotein particles, and then they look at HDL, the large and medium-sized particles, and the small particles. And then they look at the components of cholesterol and triglycerides in all of these. The result is quite impressive because technology has never been used before with this such MR spectroscopy. Well, the results were quite interesting. First of all, the role of triglycerides comes almost on the top. And these are triglycerides that are in terms of bad effects, in terms of detrimental effects, in terms of the events that we are talking about. And these triglycerides are actually, this type are in the large and medium-sized HDL. I'm saying because HDL, we all have been talking that should be protective. It depends what HDL you're talking about. If it is a high content of triglycerides, which is the large and medium size, the results are completely the opposite. And this is the first study that really points out the importance of the sizing of HDL. On the other hand, the low-size HDL, interestingly, does much better or less worse as the one that we mentioned. The VLDL, the IADL, and the LDL have actually almost equal impact. And the impact relates to high levels of cholesterol in these three molecules or these three particles, and also high levels of triglycerides. I only want to point out here is that the field is impressively evolving now, and I just want to tell you, Jeff, since you have been measuring all this stuff and I never believe on, at least I have to say to you that this is beginning to play a very important role with new technology, and I'd just like you to comment about it.
Well, let me respond in the context of different phenotypes and disease expression from population to population. And Harlan, I read your paper on China, and there is a unique phenotype among Chinese and Southeast Asians. There's definitely a unique phenotype, say, for diabetes among Asian Indians. And what you find is that this is not only in one dimension, in a cross-sectional dimension, there's complexity for one population, but across another dimension, when you go from population to population, you get different profiles. You have different profiles of lipoproteins. And in fact, for diabetes, which could be a key mechanistic driver for all of cardiometabolic disease. So in a way, the way that I look at this is I take a step back and based on the pleiotropic effects that we've already discussed about statins, we can build this complex model of chronic disease with systems-oriented approaches. In fact, we're redefining diabetes in terms of insulin resistance and abnormal adiposity. That then has effects on lipoprotein profiles. You have effects of beta cell mass, decreased beta cell mass among Asian Indians, differences in insulin resistance, whether it's hepatic or muscular insulin resistance. So I don't think we're ready for prime time, Dr. Fuster, in looking at these complex profiles and being able to have actionable results based on the population. But I think that in the future, we're going to have more precise medicine, precision medicine, by having more data that can correlate these individualized profiles with different populations, and in that way avoid over-medicalization. And let me just say parenthetically that what I mean by avoiding over-medicalization is more emphatic use of structured lifestyle. I think that we're dodging.
No, yeah, we'll talk in a moment, but
Okay.
let me ask you, Robert and Harlan, I want to ask two questions. First, Robert, do you think that this is going to evolve, this fractionation of lipoproteins?
Yeah, I mean, in addition to the paper and Jack, there's been a lot of work that Jim Matfos has done, with Mason, some of the other big studies, on the HDL subclasses and observational prospective studies in statins, and the small HDL particles, seem to be the most protective because they have a different proteome, than the large particles. And a lot of this data, came forth after they did more sophisticated statistical modeling that accounted for the LDL receptor. They also developed work with Sam Yamura, a score for insulin resistance and also Rachel Mackey, and it was tested in different prospective studies, and people that have certain lipoprotein patterns have very high risks for future diabetes.
But we should pay more attention to triglycerides. Let's go into something that is in front of us every day. And should we do triglycerides like a stress test after a meal?
Well, I mean, triglycerides are very important, and we now know that the triglyceride-rich remnants, in large part the ApoC3 containing particles, are in the causal pathway for myocardial infarction. The work from Nogastard has been very important in this regard. So yeah, I think that the triglycerides are quite important, and they may be very much related to inactivity, visceral adiposity, insulin resistance, diabetes risk. But yeah, that's an evolving area, the remnant triglyceride particles.
Harlan, we talk about China. You are very involved with China. I was in China recently twice. I came absolutely impressed by the tremendous integration in the health system of how they have biobanks and that we don't have here. I mean, I'd like you to mention, because you really are very involved there.
Yeah, and I just want to quickly respond to this issue about the subfractions. For me, as an outcomes researcher, I just want to see patients get randomized, half of them with all of this information, half of them without all this information, and to see whether or not you can link decisions that end up improving outcomes as a result, which is a different issue than whether they're prognostic, or a different issue than whether we understand mechanistically, because there's a lot to understand mechanistically. But in order to incorporate into practice, I want us to see how we use information in ways that do that. China's interesting. Both Dr. Fuster and I had the opportunity recently to be there, and I've been working there for about a decade, trying to build a national research infrastructure. In the same way that they've attacked many other areas of infrastructure within society, communication and transportation, they're very interested in building the means by which they can lead in science and technology, and they're making massive investments in order to create the opportunity. When I'm over there, I talk to them a lot about how China can become an exporter of medical knowledge. They have historically always imported medical knowledge. They've leveraged the trials and studies that have been done externally. They've been second-class citizens, really, historically, in being able to generate the kind of trials that would influence our guidelines, with only a few exceptions, like COMMIT. But increasingly, they have been enrollers in trials, but haven't been the ones out in the front leading. They have made a major commitment to large population studies, building biobanks, imaging libraries, and are eager to start to be able to use machine learning and AI in ways that might help them understand how better to predict and test strategies within the healthcare system, both within the highly resourced tertiary care centers, which are very much like ours, if not exceeding ours in some ways, but in particular in the rural areas where the village doctors have basically a high school education and are in a position where they're primarily oriented towards providing preventive care. And the question is whether decision support can help elevate their performance in ways that helps them to do well. In our study throughout China of 1.7 million people for hypertension, for example, we saw that less than 20%, something like 7% of people with hypertension actually are under control. What's interesting is I always looked at China and said, well, why do they have so much stroke compared to us? It turns out we've got more hypertension than they've got, but actually their blood pressure levels are higher than ours, because even they're growing in the amount of hypertension, but our better treatment, and we can always do even better than we are now, but our better treatment of hypertension puts them in a position where their leading risk factor is hypertension for cardiovascular disease, not lipid abnormalities. Here, it's a more balanced issue. We've got blood pressure a little more under control, where we are using more statins, but lipids are higher. I think it's not biological, but it's epidemiological. The attributable risk in China is primarily hypertension. Hypertension's more strongly associated with stroke. That's their leading cause of death. Here, we have more blood pressure, but better control. We have other issues, metabolic issues and so forth, which are leading more towards a coronary artery disease profile, and that's what we end up seeing. But they're, with great enthusiasm, seeking to develop the infrastructure. And as you may have known, that the number of articles being published in the world, actually in China now, I think just recently exceeded that from the United States, and they're on a rapid trajectory. They've still got a lot of work to do in a lot of areas to ensure the quality of the research being done there, but certainly they're on a fast track in many of the centers to be able to do things that we could only dream of. Our precision medicine initiative started in 2015 State of the Union address by Obama, and has been sort of being pursued by the NIH. I think we've enrolled 75,000 people so far. It is about to be pushed to a larger degree of enrollment, but we're many years out and only with 75,000. This study that we're involved in, which has 2 million, started long after that State of the Union address. And as you know, you've seen their ability to enroll quickly, and by the way, ethically. There's consent, there's IRBs. This is not being done. This research in the best places is being done the way that you'd like to see it done.
Thank you. Now, Jose, out of the blue, Dr. Krumholz comes with a scheme of what we should do with cholesterol, but out of the blue about something that I have not seen in the guidelines. And he mentions, number one, we all have a formula, and which can be discussed, but he adds calcification, just from the first line. Why we don't have calcification in the guidelines? Still, when in fact, a calcification of 0 means a lot, let's say. Do you use calcification as one of the risk factors that is not in the guidelines?
I use it once in certain patients, not in all of them. If I think they have major risk factors, I don't need it because the decision is already made what I'm planning to do. I do it when I am not too sure what's the next step or how far to go. I still follow. I will give the highest dose of a statin, but I may be even to be more aggressive in some people if I don't get where I want to get. And calcification might make me decide if the patient requires therapy, and number two, how to tailor it to that individual patient. Below age 40, I try not to use it because it takes a little while to calcify. It might give me a false sense of security with the patient. And after a certain age, I don't use it either. I mean, there's certain patients, but I don't use it for all comers. And I don't keep repeating it. Let's say it gives me a sense, and maybe I may repeat it 10 to 15 years later, but not yearly.
One issue is becoming clear, Robert, and that is that to repeat a calcification is useless, because you give a statin, you take cholesterol from the artery and it's substituted by calcium, so you may have a spurious increase in calcium and you think you're doing a bad job and you're doing an excellent job. So calcification basically is a manifestation of healing, which there is underlying atherosclerotic disease. What do you think in your own practice, what role plays calcification, calcium score?
Well, I treat people with, calcification as if they have, it's atherosclerosis. I don't know the severity, but I use my clinical skills, whether I'm going to, evaluate them with a stress test, and it also depends on how extensive the calcification is, how many different arteries. But you're right, the atorvastatin study, St. Francis study, put people on that agent, and then there was an increase in calcification. So, we learned something there. With regards to using coronary calcium, Phil Greenland had a paper in JAMA many years ago to show that if you had a positive CAC score, you could reclassify patients into different categories, higher or lower. So it actually makes a difference in terms of how we assess risk. And so I think it's a reasonable test, but I'm using it in people in the gray zone or people that have strong family history, where the standard risk factor profile is not giving me the guidance that I would desire.
Thank you. It became to be used overwhelmingly because of the driving by industry. Then it fell down, and now it's coming back slowly. Harlan, all the guidelines, the 5, there is something they are all in agreement. Only one thing. You know which one it is? To discuss with the patient. Now, I understand discussing with a patient who is on atrial fibrillation. I can certainly tell the patient the incidence of thromboembolism without anticoagulants. I can tell the patient the incidence of hemorrhage at age 75, and I can do that. But what are you going to be talking to these patients? Obviously, we all have to talk to the patient, but the point is, all is a great emphasis, paragraphs and paragraphs, that we should talk to the patient. And I just wonder, what are we talking about?
So this is a very good question. Let me just say one quick thing on the coronary calcium is mostly what I'm arguing is that it's about de-escalation. So for someone who's ambivalent about taking a pill, to have no coronary calcium is to suggest in the next 5 years you're at extraordinarily low risk of events. It can reclassify you. Also, the guidelines are saying anyone with diabetes should be on a statin. Well, that's ludicrous. I mean, there's a wide variety of risk associated with diabetes. For some people, diabetes is quite benign. For some people, it's quite aggressive. It's not the same disease. MESA has shown a high percentage of people living with diabetes have no coronary calcium. Guess what? Nothing happens to them with regard to coronary risk. And so the idea is that you could potentially use this to re-stratify them. With regard to what you talked to people about, I'll tell you I was very persuaded by this article that was done by Daryl Francis and his team in the UK, where they were trying to understand the disutility of taking a pill. They went to a bunch of people in London, and these people were, as I remember it, it was something like age 35 to 50 or something. It was, and they said to them, imagine there's a pill with no side effects and is free. It's free, and it's so safe. How much benefit would you need to get from this pill to be willing to take it every day for the rest of your life? Well, how do you feel about that? And it got me reflecting on either my own behavior and behavior of people I've talked to, and I realized I have some people that will take a pill at the drop of a hat. They're taking vitamins and these and everything, and there's no evidence about it, but they're basically going on a hunch it's going to be a benefit. Their disutility of taking a pill is zero. If there's any chance of benefit, they'll take it. And he saw a lot of people in his study who basically said, if I can get a day, if I get a half a day, I'll take a pill for the rest of my life. It's worth it. I don't mind taking pills. Then he saw a whole bunch of people who said, you know, I think I need to live an extra couple weeks. I need to live 6 weeks. I need to live a year. Some people said, you'd have to give me 10 years for me to be worth taking a pill every day for the rest of my life. There were about 5% of people who said that. When you looked at the whole thing and you put down what you expected benefits of statins were, it turned out, as I remember it, about 25 or 30% of people were saying they needed more benefit than statins can deliver to them for it to be worth it for them to take a pill every day for the rest of their life. Taking a pill made them feel sick. It was too much burden. It was cognitive burden to be remembering to taking the pill. And I think this is about matching our interventions with the goals. To tell people there are various paths towards risk reduction. There are various ways that you can improve your life. The way I talk to patients is I say, there's some strategies that are best buys. These are dominant benefits that most people will want to choose. There's some that are worst buys. Why would anyone want to do that? Some people choose them because they're a long shot, but most people don't. And there's this group in the whole middle. Statins, by the way, I consider a best buy. But apparently, for some people, the disutility of taking a pill far outweighs even that best buy. And that's what I think the kind of discussion we have with patients, because if you don't have that discussion with patients, you'll write a script and they'll never take the pill. You may feel better. They can think they fooled you. You cannot be honest with each other. Or you have the discussion, because if their disutility is that high, they will not take that pill every day. And you might as well know it and be able to deal with it rather than undergo the charade where you're writing a script that honestly they'll never take. And as you know, the evidence is that a very high percentage of people who get scripts for statins never take the pills. They don't fill them. Even after MIs, they don't do it. And I think that's part of us needing to understand what that disutility is. By the way, those might be the patients who would rather have an injection than take a pill. I mean, there may be other options as well, but it's something we need to learn about.
Okay, I'm going to be presenting 3 possibilities of a patient who the Europeans would put on statins, the Canadians would put on statins with a different formula, and the ACCHA would put the patient on statins on a different formula. And I want some of you, maybe you, Robert, or Jose Meller, or you, Harlan, which one would you choose? Patient number 1, very devoted to the American College of Cardiology, American Heart Association, the physician, looks at the guidelines, and the guidelines say the following. I should start statins if I have a cholesterol, or if I have a risk with the formula, which are different anyway, of more than 7.5 risk of more than 10 for a period of 10 years, or an LDL cholesterol more than 190, or diabetes. Okay, that's the European approach, the American approach. Now you go to Europe, and the doctor says, okay, let's see the guidelines in Europe. Very surprising. You need to have 10% rate of risk over a 10-year period. There is no care about the cholesterol level in blood. You can have an LDL of 80, and then tries to reach an LDL which is less than 70, when in the AHA, ACC, they don't care about the level of cholesterol that you reach. And then you decide to go to Canada, and the Canadians actually are very conservative. You need to have a more than 20% risk over a 10-year period, or you need to have an LDL more than 190, like the Americans, and you have to have, or you may have diabetes. But here, you have a goal. You have to reach an LDL cholesterol less than 70. If you look at the 3, are completely different. So Robert, which one you choose? You're in the United States, but or you choose whatever you want, because that's the problem. I don't know who remembers all of this.
Well, I think the the European approach with a cutoff of 10%, that's the number, based on our analysis of all the different guidelines and validating those guidelines. 7.5% is not the right number. But I think that we also have to understand that, Europeans are not Americans and not Canadians. We have different healthcare systems with different drivers in terms of economic costs. We have different perceptions about quality of life depending on where we live. There are many patients that are, quite fearful of having a disabling stroke, and statins certainly, can reduce stroke. People that are concerned about the coronary disease ending up with a myocardial infarction, heart failure, and then they're going to be dependent on, family members or their children. So this is where the discussion is critically important, with our, patients. But the guidelines in the U.S. are, public health guidelines, and trying to implement treatment to get the greatest benefit for the largest number of people in society. So I think the mission of those statements is not the same. It has to be put in the context of the healthcare system, the economic models, and their society.
I don't know if this is cultural, because if you go into the interventions, for example, I will tell you the Europeans are much more aggressive than the Americans, number one. In all the trials, tablets, whatever it is, they are ahead, they approve all the different devices and so forth. The Canadians are much more conservative, and the Americans are intermediary. And that's the reality. So I think it's really a matter of culture. But this leads to the point, Harlan, that do we really look at these guidelines? I certainly don't. I just learn as you read and you see a patient and you decide. Who in the world is going to remember everything that I said here?
So I agree with you. My answer would be I would talk to the patient. And I think you have to understand what the critical pieces of information are. One is what's the likely benefit for them, for that individual, based on what you know. And by the way, this thing is 7.5 or 10. I don't think any patient understands the difference between 7.5 and 10. It sounds about the same to most people, 7.5, 10, 11, 12. That sounds for most people like the same risk. So to make an artificial boundary where you're going to jump over, it's just a guideline. It's saying when you get around this point, it seems like it's a reasonable decision. But what I would try to understand is what's the benefit and how do they feel about the things that they're being benefited for? What's the risk and how do they feel about those risks? And in some people fear certain risks more than others. So this is what being a doctor is about. But you want to be informed with as precise of information as possible for them. And then you want to understand what the burden is to them. And the burden is what I talked about, this utility of pill, but it may also be cost. What's their out-of-pocket cost? How much financial toxicity is associated with it? Well, fortunately for statins, there's not a lot. But for some of the other strategies, the financial toxicity is a lot. So the guidelines are giving you general guidance of the things that experts are thinking about for you to take into account. What I don't like is when there are certain categories like diabetes that include a very heterogeneous group of people, and we're basically just saying, bang, that's a CAD equivalent. I think that's an old way of thinking based on an old article. I think in the future, we'll be getting more precise estimates, and we can sit down with patients and say, here's what you might expect to gain. Here's what risks are associated with it. What do you feel? How do you feel about that stuff? And then what's the burden to you? And personally, both, including financial. And then we're going to have to be doctors because there's nothing that's going to come out of a computer that's going to say treat or no treat. And I believe that forcing people into a guideline with silly boxes and say, no, you're in this box, so I have to write you a script is silly. These are guidelines. They're general directions to help people sort of place into perspective what experts are thinking are important considerations. But I think as a doctor, you need to be able to dig into risk, benefit, and burden, and then work with that person to figure out what their goals are and come up with a plan. And I think that you'll get a lot more people following through with the plan if it's been made as a sort of contract between you, and also that it can be revisited. Let's decide now, it's prevention. We can talk about it again to see how you feel about it. And I think that's a better path than, we shouldn't be teaching people, and neither should we have quality measures that say, this person was in this box, did you treat them the way this box said? Because it's just not the proper way to practice.
Gene, I'd like to say very briefly something, because I think this is very, very important, is to get the person involved. And all these percentages are worthless. They're absolutely worthless in talking to a person. You can feel it if you take those guidelines, but they don't get it at all. So I think coronary calcium scores are the way to try to put people, and using cross-sectional data from 25,000 people who were done in men and about 10,000 in women, back in about 10 years ago, when people weren't on statins. And if you get up to 400, basically you're at a coronary risk equivalent. And if you take a person, whatever their age is, and show them where they are using cross-sectional data, And when they'll get to 400, then they start thinking about end of life. And that's a meaningful sort of thing. If they want to get to 90 without anything, and they say that they're going to be at 400 at 65, boy, that really it tells them something. The other thing that can help, just one other thing, is that how do you tell a person what's going to be doing with their plaques once they start getting on statins? And the Glagoff trial cannot be forgotten because they took people, 1,000 people, they put them on the PCSK9s and other things, and they looked and followed them and looked for 18 months over what the intravascular ultrasound showed of a 15 millimeter plaque. And so once you get down to 80 for LDL, half the people continue to make plaques, half the people decrease plaque size. So at 80, the average person stops making plaques. But you have to get to 60 where 95% of the plaques are shrinking. So by showing those pictures to people, where you are, this is your LDL, this is what's happening to your plaques, this is going to be your expected lifespan based on your calcium score. So that will help them to understand it. So the MESA risk score, if you put in the calcium score and all those different variables, it will be a major help, and it will stop you from treating people who you think should be treated and start on people who would seem.
Okay, thank you very much. I want to finish by something that's very exciting, and it's happening at this minute. It all started with I'm talking about young people. Should we give statins to somebody who is age 35? This is the question. And it all started with a registry, with a number of institutions, Mayo, the Brigham, Mass General, in which they look at people who had myocardial infarction under age of 50. And there were actually 1,500 patients. Of interest, the type of a score was less than 4% in 80% of these people. So going for guidelines, very few would have been on statins. So that's number one. And what they point out is that we have forgotten the young people. I don't talk about the elderly people today. We have forgotten about the young people where the disease is beginning to evolve, and actually the scores may be much lower than what we are requesting to give statins in the adult population. But this is leading now to the American Heart Association to begin to develop a strategy which I find quite fascinating. And that's basically you multiply the baseline, your LDL cholesterol, like for example, 125 milligrams per DL, you put the age and you multiply by age, in this case is 40 years. So then what you have is 5,000 milligrams per year. And they have calculated that this leads to an incidence of cardiovascular events of 1%. So then what you do the same. If you have rather than 135 or 140, 60, you increase the incidence based on the accumulation of the time that high cholesterol or LDL is circulating. This actually makes sense. What is interesting of all of this is the concept that to treat the patient when the disease is very advanced, or when this product is very high, probably the chances of having success is much less that if you start treating the individuals, for example, at age 30, age 40, I'm talking about statins, for example, or even diet that we have not talked today and is very important at this early age, which will prevent the disease to progress. Well, this is certainly a driving force at the present time. And I am involved personally in 2 trials in beginning to give statins in people under age of 50. In this case, with LDL cholesterol, which is, we didn't look at the product, with LDL cholesterols that are more than 120. One study is actually in Canada, and the other study is in Spain. What I'm really trying to say is, are we missing the boat with all this cholesterol? Obviously, ideally, the statins don't have side effects. But what I'm really talking about is to take care of people at much younger age. And this is coming from all venues, and this is one of them that I just wanted to comment on. Harlan, do you have any final comment about this?
Yeah, I mean, I think it's a fascinating idea. The question is, what's the dose? what happens when you treat people over a lifetime. I mean, I think studying this is worthwhile. You know, Spain is already low incidence of cardiovascular disease. So I want to rather understand what the lifestyle is in Spain that's leading to that. You know, I compare Norway and Spain. They're on, even for the increment of cholesterol, the amount of risk, they're in very different directions. For the slope of the curve, as you increase cholesterol with risk, looks very different in Spain than it does in Norway and Sweden and so forth. And, you know, the questions for me are, well, why is that? And so if you're going to start treating, you know, it may be that in Norway that makes sense, in Spain maybe less so.
Well, the approach, I will tell you, the approach is half of the LDL appears to be acquired by the alimentation and half is genetic, I mean, more or less. And the question is to start measuring at age 4, age 7, age 10, age 15, and to know if there is a diet component or if there's a genetic component, which you can cover. And if there's a dietary component, you may have a tremendous impact starting at young age with real data. And this is what is actually evolving. I think it's exciting. Well, anyway, we talk about cholesterol. We talk enough about it. I'd like you, any questions? We have 5 minutes.
I would have thought that the genetic people would be the ones you'd want to. If you had a strong family history, I would have thought that those were the people that you would want to start early.
Well, familial hypercholesterolemia, I can tell you the figures. To have a genetic familial hypercholesterolemia is really you are dealing with a very small percentage of the population, about 2% or so. So it is not so clear. Many people have family histories, but there's no genetic mutation. It's just for one reason or another, maybe the way they eat or whatever it is. I don't know if you have any comments, Robert.
Yeah, so Neil Stone and Joe Goldstein at NHLBI had a 20-year prospective look at FH, and in men, heart attacks begin at the age of 20 and women 35. So we really want to do better screening for patients at very high risk, those with heterozygous or certainly the homozygous FH patients, and I do treat those young individuals.
Other comments?
There are no questions about cholesterol. I would like to have your opinion about the other lipid that now is becoming very fashionable. It's Lp(a). What is your take about this?
Lp(a) is very important. And what you find is some people who have very fairly normal LDLs, basically given that just postmenopausal, they'll have a heart attack and wonder what in the world is going on. And you look and it's a high Lp(a). So I do that once in everyone when you get a lipid profile just to see where that is. And if it's relatively high, then it is a concern. And especially if you're at an age of, say, 40 and above, where coronary calciums will sort of be reasonably tell you what's going on inside, you may find them way ahead of where they should be in terms of their age. On the other hand, some people, for some reason, have very high Lp(a)s, and it doesn't make any difference at all. And that's why always looking at something like coronary calcium can help after the age of 40 and that sort of thing to sort of tell you what's going on in terms of the development over a long period of time.
But how do you change your management? This is the key.
Well, what you do is then you determine whether you want to just simply lower the production rate, or whether you want to stop the production, or whether you want to decrease. And the person will tell you what they want to do. Once you start showing them at what levels where the plaques are, and it's just a graph that comes from Glagoff, and then you can just show it to people. They can make their own decision.
Robert is involved in the trials with.
Yeah, so the Lp mass has been the standard. It was Lp cholesterol, now Lp mass with the protein, but we can do better. And from Mendelian randomization studies, the Kringle-4 repeat provides more information about risk than just Lp mass. And then there's a functional domain on Kringle-2 that's important in terms of oxidation. And we've actually been funded to do a study looking at all these different parameters, and the Regards study and looking at genetic mutations. What do I do with that information? I still use niacin in somebody with heterozygous FH who has a high LPA, they're on a statin, ezetimibe, or they may have a high LDL cholesterol, and I'll use that therapy, or sometimes I can justify using a PCSK9 inhibitor because the LPA mass is elevated. I think we still have a paucity of data, though, about showing the reduction in LPA. We're involved with the antisense therapy, Isasaxia, and that therapy lowers LPA by about 90%. But the outcomes, this is a dose ranging study, and we're waiting for the outcome study to begin once we find out what the right dose and dosing regimen is. And it's really going to take that type of information to push LPA forward.
Juanjo, I have a number of patients who develop problems at young age with very high LP little, particularly Asians. I use anticoagulants, and you know why. Because of it's mimicking the plasminogen activator. It's all obviously personal, but this is the way, because if you cannot drop it down with any other thing. I'd like to finish by asking two people, Michael and you, to give us final message to us. What did you learn, Michael, with all of this today? What do you go home with that perhaps is the most striking aspect?
I think the takeaway message is that we're probably all a little bit confused as to what the guidelines mean. But I think it is an individual discussion between the cardiologist and the patient. And I think that before the recent medications, PCSK9 inhibitors and Zetia, it was more of a moot point, the targeting cholesterol, because you couldn't really get down to LDLs below 70 for patients who had a very high LDL. Now that these medications are available, I think it reopens the discussion a little bit more, and the future is a little bit more interesting. It's probably more about how low to go and how cost effective, because if you can get LDLs to 50 and below, you might just be able to prevent atherosclerotic disease development. So the future is a little bit more interesting.
Thank you. Harlan, final comment?
Yeah, I think the main point for me is just this point I want to emphasize, which is you can make someone's labs look better, but that doesn't necessarily make them look better. And that's why we have to ultimately do these trials. We need more trials that help us understand what the effect is. As we're producing more information, we need trials on, does the information actually provide information that changes decisions in ways that benefit patients? We need to know, bottom line, does either certain strategies or certain, including information, actually help us do better by the patient? And then the final thing is, I think these guidelines with boxes are just meant to be guidelines. They're teaching tools. They can tell you general approaches. But when you actually are sitting down with individual patients, as you all know, and as these wonderful physicians exemplify every day, you're sitting down with that individual, understanding what their goals are, trying to convey what's to be gained, what's at risk, and what's the burden on them to pursue different strategies, and helping them to choose the right way. This is particularly important in prevention, where the benefits only realized years ahead, and yet you're asking them to do something in the interim. If they're not bought in, because they're not taking something to relieve a symptom, they're taking something to avert something far in the future, at least in their minds. And if there's any hope that they actually will follow through, it has to be something they want to do, that they see the sense of, that's aligned with who they are. Otherwise, you're going to see what we see now, which is half the people who are prescribed statins never ever take them. And I think that we need to move to a point where there is really that kind of conversation going on between patients and doctors who can authentically share information about values and goals and help achieve them.
Okay, thank you very much to all of you.